Bismillah ar-Rahman ar-Rahim. Welcome back to the UCAN presentations. Today I would like to talk about a practical approach to a pediatric cardiac anesthesia case. Just how we approach this case, how we do the pre-operative assessment, and how we create a plan. I will do my best to avoid any theoretical issues, just aiming for the practical steps and targeting the beginners in pediatric cardiac anesthesia. I will divide this topic into two presentations and two videos. The first will be about the preoperative assessment and optimization of the patient before the day of the surgery, and the second will be about the theater day. So my presentation today is focused on the patient who is admitted to the ward waiting for his surgery. Either this patient has come already to do an elective procedure, or this patient had been admitted to the hospital in a critical situation and stabilized and then is ready to go for elective surgery in the same admission. So PICU patients are different and they need a different approach. So I have a patient on my list tomorrow. From where should I start? In most of the cardiac centers, most patients would be presented in a meeting, and this meeting will include the cardiac surgeons, the cardiologists, the anesthetists, and other members of the team who are looking after the congenital heart disease patients. Um, and this is to discuss the patient and to take decisions. This meeting is called JCC, or Joint Cardiology Cardiac Meeting. Sometimes in other places it is called CHMDT, or Congenital Heart Disease Multidisciplinary Team Meeting. And the meeting will discuss the cases and give a very detailed report that is tremendously useful for us as anesthetists. Actually, because it is a ready-made handy tool for the pre-anesthetic assessment, it would contain details about the patient's age, weight, allergic reactions, the original cardiac lesion, any cardiac surgery or cardiac catheter, and its report, and other medical issues, and also the patient's current medications, like Prostin, Milrinone, heparin infusion, diuretics, beta blockers, ACE inhibitors, digoxin, and non-cardiac medications as well. It will also highlight the relevant past history. The JCC report also shows the ECG, the echo, X-ray, and sometimes it has a cath lab report, CT, MRI, bronchoscopy. It also includes the last clinical examination done by the cardiology team, particularly oxygen saturation and signs and symptoms of heart failure. It will give brief notes about the discussion and the decision. And the decision would be something like that: waiting for the baby to gain more weight, or to ask for further investigations and reevaluate again, or to decide the surgery. And if the surgery is to be done, so the team will decide what is the surgery, what is the priority of the surgery, and the team will estimate the expected risk of morbidity and mortality for this patient. After getting all the useful data from the JCC report, we can continue our pre-anesthesia assessment. So the JCC gives us about 80% of the preoperative assessment data. Then we will add to that any recent changes in the child condition from the JCC date until now. A quick examination is useful, mainly focused on lung condition, increased work of breathing, oxygen requirements, whether this patient is in room air or face mask or high flow nasal cannula, his saturation, signs and symptoms of heart failure, and any complications related to his cardiac condition. We will review the medications, particularly if there is infusions like Prostin, heparin, or Milrinone. Regarding feeding, it is advisable to know the type of feeding and if there is any difficulty. Is it oral, nasogastric, is it peg tube, or TBN? We would also consider the risk of hypoglycemia if we stopped the feeding for fasting before surgery. We would also consider maintenance fluids for patients with a very high hematocrit to avoid any thrombotic events. We would also review the lab results to see any significant derangements. To avoid delay in the morning, we would like the blood cross-match to be ready the night before the surgery. Some babies may need irradiated blood to avoid graft versus host reaction, and this is a concern in patients who have DiGeorge syndrome, which is common in certain types of cardiac lesions. Viral studies such as rhinovirus, and respiratory syncytial virus, rotavirus, adenovirus. This study is routine in some centers to exclude significant viral chest infection. This may delay the surgery actually in some cases when the high pulmonary vascular resistance is a concern in this lesion. The sedation pre-medication would be considered for patients more than 1 year when the patient has any behavioral issues or bad experiences with the previous anesthetic. Regarding the IV access, we need to know what IV access the patient has, and we need also to know if there is any concern about his vessels, like a previous cath lab or pediatric intensive care admission that already destroyed some of his veins and arteries. Now, as we know everything about the patient, this is the time to create a plan in our mind and discuss this plan with the patient's family and discuss the possible anesthesia risks in this case. To be honest, it is very rare to cancel or delay a case by the anesthetist. It would be very, very frustrating to the family and also very difficult to convince the surgeon. So you need a very strong convincing reason to do that. I have to say that the most important part in the plan is the redo precautions. You can imagine what would happen if this saw on the left cuts into this sternum on the right. The surgeon, of course, would not use this saw to open a redo patient. There are different techniques that are safer, but it is still very risky and can cause massive bleeding. After previous sternotomy, it is very common for delicate structures like the aorta, pulmonary artery, right atrium, right ventricle to be adherent to the back of the sternum. The main issues with the redo is massive bleeding caused by injury to important structures or triggering VF because of using the diathermy, and both of them can lead to cardiac arrest. Because of the risk of massive bleeding, the anesthetist should be ready by blood, which is checked and ready to go, by big IV lines or pulmonary catheter sheath if the patient is adolescent or adult, maybe also by rapid infusion devices, and also by a good dose of heparin ready to go in case we have bleeding. You don't want to give a heparin dose and then you find that the ACT is less than needed when the patient is bleeding. You need a good dose that you will be sure that it is enough and it will get the target of the ACT for the surgeon to just start bypass and do sucker bypass for during the bleeding. Despite being an anticoagulant, so the heparin is anticoagulant, heparin during massive bleeding in this situation can be life-saving because it will allow the surgeon to suck the blood into the bypass machine without being clotted and then transfuse it again to the patient when the surgeon is able to insert an arterial cannula. And this technique is called sucker bypass. So if there is an arterial cannula and there is bleeding anywhere, it's not a big issue. The surgeon will put the suction into this blood and it will be sucked to bypass and it will return back to the arterial side, and this will give some time for the surgeon to control the bleeding. This is called sucker bypass. So using heparin in this case depends on how fast the surgeon can get an arterial cannula. Another way to avoid patient's collapse is starting femoral bypass before opening the chest. And the surgeon usually opts for that if the possibility of massive bleeding and the injury during sternotomy is high. With reduced sternotomy, there is risk of VF because of the using of diathermy very near to the heart. So a chest DC shock adhesive pads on the chest connected to the DC defibrillator can be a wise idea in this case. So it is like a routine for every new patient to put the adhesive pads and connect it and keep it ready during sternotomy. So because of the risk of cardiac arrest, whether this is because of the bleeding or because of the VF, putting ice on the head may help a better neurological function recovery in case of CPR. The preoperative fasting can cause hypoglycemia, can cause dehydration, or increase the blood viscosity. So we need to make a plan to avoid hypoglycemia. If this is a tiny baby, this may be by dextrose infusion. We also need to continue having clear fluids up to 1 hour before surgery if less than 1 year old, and up to 2 hours before surgery if the patient is more than 1 year old. If the patient is on TPN, we continue the TPN or stop it, but if we stopped it, we have to replace it with dextrose 10% infusion. Cyanotic patient would have impressively high hematocrit of 60 or 70, and this will cause risk of strokes, and it is advisable to have intravenous access and to have maintenance fluids during the fasting time. Regarding the sedation before coming to theater, I would like my patient to be snoring rather than to be crying. It is rare to need a sedative premedication for a baby, a child less than 1 year old. It is ideal to give sedative premedication for autistic child or any child with any behavioral issues. It is very useful to review the previous anesthetic charts if the patient had surgeries before, because I would be able to see how anxious the child was during the induction and whether the patient received premedication, what premedications he received, and was it effective or not, and then decide what I'm gonna do for this patient this time. Single premedication is usually oral midazolam, half milligram per kilo, up to 20 milligrams. And sometimes we need double premedication, which is midazolam and the clonidine as well. The clonidine dose is 2 to 4 microgram per kilogram. I will consider the effect of the sedative premedications on the conscious level, on maintenance of the airway, on ventilation, on hemodynamics. Just be wise, because some patients may just collapse with a high dose of sedative premedications. I will stop here, and I will talk about the intraoperative management in the next video. Please, if you have any comments about the presentation, whether it is a good thing or a bad thing, please write your comment down under the video. I would also encourage you to join our UK Anesthesia Network Facebook group, and also subscribe to this channel, and have a nice day.